Hello, everyone. Let's move on to a slightly different topic, to the topic of the interconnection of psychology and somatic medicine. My topic is about the investigation of the birational relationship between pancreatitis and psychological conditions. But before I say anything, I want you to think of a patient or patients where you got the diagnosis right, you got the treatment right, and for some mysterious reasons, it didn't work out. Because of non-adherence, for example, because of bad communication between doctor and patient. My topic has something to do with this question, so let's dive into it. But before I do that, just a few words about myself. I'm a clinical psychologist with a vision of a patient care where GI problems will be better prevented, mitigated and cured by psychosocial medicine. And we talk about missions. My mission would be the development of psychosocial interventions and prevention programs. But again, first, you've got to have specific goals to go with. My first topic is the investigation of the prevalence of anxiety and depression in patients with pancreatitis, which of course is a systematic review and a meta-analysis. And the second one is the investigation of the risk factors and the dynamics of anxiety and depression, again, in patients with acute pancreatitis. This project is from September 2023, and the planned submission date is May next year. Just to give you a basic knowledge about the background of this topic, we already know that there is a bidirectional relationship between the brain, the gut, the microbiome, and the psychological variables. We know that. We also know that depression increases the risk of chronic diseases and vice versa. For example, if you look at the question of IBD, we know that the prevalence of anxiety is 20%, the prevalence of depression is 15%. But the problem is that for chronic pancreatitis or for acute pancreatitis, we do not have these numbers, yet we think that these result in worse clinical outcomes. So the aim would be the exploration of the prevalence of anxiety and depression in pancreatitis. Of course, we would use a COCO-POP framework for this. In the first co, it would be anxiety and depression, and then acute and chronic pancreatitis in the second one. And of course, we are talking about adults with the hypothesis that there is a high prevalence of anxiety and depression in patients with pancreatitis. The implications would be threefold. First, for policymakers, what would be necessary is the revision of the guidelines. For patients, we believe that the reduced levels of anxiety and depression would result in better clinical outcomes. Simple as that. And for research implications, if we have this data, the new GI psychology interventions could be created later on. We did the systematic search. In the first domain, there was the pancreatitis item, and all the other items below are from the psychological and psychiatric literature. We started with over 8,000 hits, and then after duplicate removal, it was 7,000 approximately. The title abstract part is done. We are, each and every single one of my team is at 100%, so soon we are beginning the full text selection. Concerning the next topic I showed you earlier, the investigation of the risk factors of psychological conditions, this started in November this year, and the planned submission date is September next year. We have three clinical questions here. First, what is the dynamic change of psychological variables during the acute pancreatitis phase? Again, let's start at what we know already. The research says that the psychological experience of inpatients with AP could be characterized by a feeling of unpredictability, varying degrees of stress and social support. But you could ask the question, of course these people are stressed, of course they are distressed. The question is how much they are and what's the connection between these symptoms and their clinical outcomes. For example, if you look at anxiety, we already know that there's no significant change during the first 7 days of hospitalization. But for depression, we see that first it increases and then it decreases. So the aim would be the exploration of this dynamic change of these variables during the acute phase. For this, we would use a PECO framework. Of course, it would be a prospective observational study with assessments done on an every week basis by psychologists starting from admission, basically. Now for the second question, what are the risk factors leading to these worse psychological assessment scores in AP? We have to see that the possible risk factors are quite numerous. For example, underlying mental disorders, negative health habits. We already know that smoking and alcohol consumption are items to deal with here. But what about psychiatric indicators like emotional lability or stress modulators like pain sensitivity? One possible solution would be finding the most vulnerable population at admission, and then follow these people when they are in the hospital and even after they leave the hospital. So the aim would be the exploration of the risk factors of these unfavorable psychological assessment scores. This would require a PFO framework with the hypothesis that psychosocial factors contribute to this high level of anxiety and depression in patients with IP. And the implication would be, again, that after this most vulnerable population is found, it needs to be identified at admission, and their course, disease course, needs to be followed up during their stay at the hospital and even after. And the last question, how do psychological assessment scores influence the clinical outcomes of acute pancreatitis? You can think of this question as the last one. All the previous ones are leading to it, because we know, again, that mental disorders in general elevate the risk of adverse clinical outcomes. If you look at this slide, you can see that patients with heart failure were studied, and the attributable risk has this nice linear connection with the prevalence of depressive disorders. But again, do we have these numbers for acute pancreatitis? We don't. First, we need to produce these numbers, and then a possible solution would be prevention targeting. So again, reducing the incidence of these adverse clinical outcomes with the aim of investigating these psychological alterations that may affect the clinical outcomes of pancreatitis. Again, this would result in a PFO question framework with the hypothesis that unfavorable psychological assessment scores could worsen the clinical outcomes of AP. And the implication is quite simple. Close monitoring and psychological interventions need to be provided for this most vulnerable subpopulation. So again, these are the topics. I welcome your questions. And please don't forget, the first wealth is health.
I would like to congratulate you. It was a fantastic presentation. The session is open for discussion, please.
Congrats, Tibor. One easy question. Are the tools that assess anxiety and depression specific for pancreatitis, or they can assess any kind of disease that is associated with anxiety and depression?
More general assessment scores could be used. Again, back to my previous points, if these assessment tools, questionnaires, forms exist, why not use them for acute pancreatitis? They are. So in a way, I try to correct my previous statement, but if you look at these previous publications, the sample size is rather small. So at our institute, at our unit, we now are using these questionnaires from admission and then at the regular checkups. And in order to answer your questions, these are not specific to pancreatitis, but they were not necessarily used for acute pancreatitis. But again, we are also thinking about creating new ones for chronic pancreatitis.
Thank you.
Thank you for your question.
My question is about the second topic. You are planning to look at how acute pancreatitis influences the anxiety levels, the depression levels. However, maybe some of these patients who are alcoholics or they already have a baseline anxiety, depression, comorbidity associated. How do you plan to investigate this or approach this in your study?
Mm-hmm. We have quite a few examples from the literature that are not connected to pancreatitis. First, they had to be assessed by clinical psychologists or sometimes by psychiatrists as well in order to find these other conditions that were there, and then became the wonderful territory of statisticians and psychologists working together, because those modulating factors needed to be found. For example, just a simple answer to your question would be smoking and alcohol consumption. We know that people who suffer from psychiatric disorders tend to smoke more, consume more alcohol. But again, is that in the independently connect to this topic, or the fact that there is a psychiatric disorder present is like a modulating factor?
Just imagine a patient who's admitted with severe acute pancreatitis, vomiting all the time, severe abdominal pain. Would she or he be willing to work with you on the first day?
Our experience is the following: probably not. But we try to come to their help as soon as possible. And when I say as soon as possible, we would be shocked, but sometimes they welcome the psychologist's help on the first day of admission. And sometimes, of course, they send us away, but in a way it's understandable, because first they have to deal with their very serious somatic conditions, and they can open up about their conditions later on. But I'm giving you general data because there are some exceptions, but on the first day and the second day, usually most assessment scores are done at our unit.